Thank you very much, Dr. Adams. Our next and final speaker is Dr. Stephen Davis, who is Professor of Translational Neuroscience at the University of Melbourne in Australia. He's the 2011 winner of the William Feinberg Award, and he's going to be speaking on penumbral selection for reperfusion therapy. It's about the brain.
Well, thank you very much, Bruce, and good morning, everyone. It's an absolute pleasure to be talking with you this morning. I'm going to talk to you about penumbral selection for acute reperfusion therapy and just have a look at the past, the present, and a gaze into the future. Now, a book was written a few years ago by my close colleague and friend Jeff Donnan, shown there, the Ischemic penumbra, and a group of us, including Jean-Claude Baron, who is probably here, that really tells the story. And the story perhaps begins just a little earlier when we think about modern stroke medicine with C. Miller Fisher in Boston, Peter Bladen in Melbourne, and Fieschi in Italy, showing that ischemic stroke was largely due to thromboembolic but transient occlusions of cerebral vessels that then had delayed recanalization with tissue damage. And really, with that basis, the seminal work on the concept of the ischemic penumbra was led by a neurosurgeon. Don't seem to have the laser there. Lindsay Simon, shown there in the glasses. I'll just go back a slide. Shown there with his group in London, working on a primate model. Lindsay Simon was a highly esteemed clinical neurosurgeon, head of neurosurgery at Queen Square, who was given 20% of his time for research. With his colleagues, he came up with this concept that around the infarct core there was what they called the intermediate zone, where cells were threatened by critical hypoperfusion, lowered cerebral blood flow in the region of 20 mils per 100 grams per minute. And they speculated 40 years ago two hypotheses. First, that in vivo measurement could be made of the ischemic penumbra using imaging techniques. And second, that reperfusion could salvage at least some of this ischemic penumbra. So I want to look with you at what changes have occurred since that time and where we are going. But first, let's just look at a simple schematic of the ischemic penumbra, which embodies these concepts. And you'll see that the embolus usually comes from a proximal source, either the heart or typically the extracranial vessels, and that very rapidly, deep in the typically the lenticulostriate region, cells die very rapidly. And this is the most vulnerable area in ischemic stroke, in middle cerebral artery occlusion. And as you know, there is a variable region of hypoperfusion around that core termed the penumbra. And what happens to that region of hypoperfusion depends on two critical factors. Firstly, what happens to that embolic occlusion, and secondly, the state of the collaterals. And in the absence of reperfusion or good collateral circulation, there's typically expansion of that ischemic core into the infarct region. Now, I remember with excitement in around 1980, the first images of the ischemic penumbra were produced, in fact, with positron emission tomography, work done by Jean-Claude Baron and Bob Ackerman in Boston, by Richard Frkowiak in London, later by Dieter Heiss in Germany. And they showed that an elevated oxygen extraction fraction, or misery-perfusion, demonstrated the brain working very hard to extract every molecule of oxygen from underperfused tissue and survive, but that typically this region went on to infarction. In fact, I remember in those early days we were talking about hypertension induced hypertension as a way of salvaging the penumbra. So we all live and breathe these time is brain curves, and you can see here up on the top left the curve for intravenous TPA, where there's the waning efficacy over time, and a very similar story now with endovascular thrombectomy. So a progressive diminution of benefit, increasing numbers of patients needed to treat, around 4.5 to 5 hours for intravenous lysis, around 7.3 hours for thrombectomy, regardless of imaging status. Now, the reason for the time is brain curve is very simple, and that is that the ischemic penumbra declines over time. This was early work performed here by David Darby from our group in Melbourne, but similar work's been done by other groups, showing that the frequency of the penumbra reduces, but is still present in many patients beyond 4.5 or beyond 6 hours, the licensed time windows for TPA and thrombectomy. We know that the penumbra, shown here with MRI mismatch, is the basis for reperfusion therapy. And what's very interesting is that if you treat patients ultra early, you can achieve even greater benefits. With mobile stroke units now, up to 40% of patients can in fact be treated in the first 60 minutes after the onset of symptoms. There are virtually no patients in the clinical trials shown in the Embersome meta-analysis here treated in this time window. And these patients have an even greater propensity to achieve a very early reperfusion and benefit. And one would assume that virtually all of the tissue, or a much greater part of the tissue in these patients, is penumbral. So the real interest in penumbral imaging has been particularly to look at selection beyond the clinically established time windows. And I personally would not be advocating advanced imaging as being necessary before intravenous lysis, and possibly not before thrombectomy either, because time is brain, we need to move fast. We do find it produces some interesting information. There was work by Bivard and his colleagues in Newcastle, in fact showing that retrospectively, the only patients that benefited from TPA within 4.5 hours were those with the penumbral signature mismatch. But it's predominantly to be used beyond the established time windows or at uncertain times. Now, Jeff Donnan and I ran the Epithet trial in Australia. Our colleagues in Stanford, led by Greg Albers, ran the Diffuse program. Epithet, we randomized patients 3 to 6 hours and looked at those with the penumbral signature on MRI, and you can see this perfusion-diffusion mismatch. And we showed that we doubled the proportion of patients with major reperfusion using TPA compared with placebo, and that this reperfusion benefit directly correlated with neurological and functional outcome. Our colleagues in Stanford made very important contributions in non-randomized studies in Diffuse, developing the target mismatch concept and the malignant pattern concept. So target pattern was patients with thresholded mismatch, so benign oligemia being excluded, and malignant mismatch were those with massive cause who were shown not to benefit from reperfusion and to be at high risk. And in Diffuse 2, they took things further with an endovascular study and showed that firstly, endovascular reperfusion only benefited those with target mismatch, not lack of mismatch, and that the target mismatch was time independent. So patients 0 to 6 hours benefited equally to those 6 to 12 hours. And you can see the green on the left there represents the reperfusion group, 6 to 12 and 0 to 6 and 6 to 12 hours, and they are equivalent. So we're taking this further in extending the time window with our Extend IV trial. This is headed by Jeff Donnan, who's here, Henry Ma, and myself, and a group of investigators in Australia, Taiwan, and Finland. We are using CT perfusion, which we validated under Bruce Campbell, against perfusion-diffusion mismatch using automated rapid software. And we're looking for this kind of pattern, this typical mismatch between thresholded perfusion, Tmax of 6, and the ischemic core. And we've excluded patients with very large cores in this trial. And we now have 180 patients in Extend IV, trying to double the time window for TPA and look at those with wake-up stroke, which, as you know, constitute about 20% of our patients with ischemic stroke. We're going to perform a sample size recalculation at 200 patients, and we believe that this trial will really give us the answer as to whether we can give intravenous thrombolysis at a delayed or uncertain time window and change clinical practice. Now, our colleagues in Europe, led by Werner Hacke, are performing a very similar trial, ECAS-4, which is proceeding well, and there is close coordination between the trials. Now, our colleagues in Europe, led by German colleagues, Gerloff and Tomala, are using a very interesting but analogous concept in the wake-up trial, and Japanese colleagues in the Thor trial, and they are using DWI flare mismatch, so MRI-based trials. And the concept is that very early on after ischemia, as you know, you get an acute DWI lesion due to ADC restriction, but flare, which represents the changes on flare, the breakdown of the blood-brain barrier with edema, takes some hours to develop. And the hypothesis is that that mismatch between DWI and flare represents salvageable tissue. Vincent Thies has shown with his group in Belgium that DWI flare mismatch is strongly associated with perfusion-diffusion mismatch on MRI, and that in fact if you have both patterns, it correlates with an earlier time of onset from stroke. The wake-up trial is nearly completed, and I think will be a very, very important result for our field. Now, the most dramatic breakthrough in modern acute stroke therapy has been endovascular thrombectomy. And to paraphrase Churchill, perhaps this is the end of the beginning of acute stroke therapy. TPA, the story beautifully told by Clark Haley yesterday, followed by, in the last couple of years, the proof of endovascular thrombectomy. Now, there are many unanswered questions. What is the role of penumbral selection in those within the time window, which is now 6 hours, it may become a little longer, and beyond 6 hours? Can the time window be extended using penumbral imaging and penumbral selection? This is being tested in the Dawn trial, led by Noguera and Tudor-Joven. Very important trial, looking out to nearly 24 hours to see whether patients, they are using another concept of the penumbra, clinical to core mismatch, which is another way of looking at penumbral tissue. And the Diffuse 3 trial, led by Albers and colleagues, is also looking out to around 18 hours, using penumbral selection, automated imaging with CTP. And we all see patients who come in at delayed times, 12, 14 hours after stroke onset. If they've got a favourable penumbral pattern, the hypothesis is that thrombectomy will be beneficial. These are critical trials that I think, again, could change the way we practice stroke therapy. What about treatment of large cores? This was addressed by Bruce Campbell yesterday and the Hermes collaborators. And Bruce showed that, in fact, many patients with large cores do benefit from thrombectomy. Now, they have a worse prognosis overall, but there is a treatment effect. And at the present time, the Hermes data, and admittedly there are not many patients with large cores, so I think some caution is needed in interpretation of the results, suggests we have to be very careful in excluding patients with large cores, particularly younger patients, earlier time of onset. We perhaps should be a little wary of excluding patients, for example, with greater than 100 mils of ischemic core. And there are many other questions, of course, in the thrombectomy field, whether we even need preliminary intravenous lysis, whether we can go directly to the cath lab in patients arriving at a comprehensive centre, just like the cardiac paradigm. Now, what would you do with this patient? Here's a patient arrived, this is a 45-year-old patient arriving with stroke onset, say 7 hours earlier, with a large perfusion lesion, significant perfusion to core mismatch on CTP, but a very large ischemic core. And at the present time, we don't know, but I think the important message from the initial Hermes data is don't necessarily exclude them because they have a large core. And I think that the further answer to this will be probably provided by clinical registries rather than randomized controlled trials. Now, the other factor about the penumbra is that penumbra is dynamic, that CTP thresholds are time dependent, and very severely hypoperfused tissue, shown there in red, can be rescued if the treatment time is very early. So the penumbra changes, and over time, tissue is more difficult to rescue. So again, we need to move early, whatever the penumbral pattern. Now, some of you may have read the recent book by Thomas Friedman, the Thank You for Being Late, where he talks about that we live in an age of accelerations. Acceleration in terms of technology, in terms of globalization, and in terms of climate change, and how we should adapt to those very rapid changes in our environment. And he quotes Moore's law. Gordon Moore, in 1965 at Intel, predicted a doubling of computer power every 18 months or so, which becomes an exponential increase, which we all are living with. For those of you working on iPhones currently, you're aware of the very, very rapid changes in technology over the recent few years. Now, JFK stated that change is the law of life, and those who look to the past or present are certain to miss the future. So the future of modern stroke therapy, I believe, critically began 40 years ago, based on the earlier work of thromboembolism to cerebral vessels from proximal sources, but 40 years ago with the Simon description of the ischemic penumbra, then led 20 years ago to intravenous TPA, becoming the standard of care, and more recently to endovascular thrombectomy. So in 40 years, we've come an incredibly long way. We have a lot of work to do, and we need to look to the future. We've had many failures in the stroke field. Churchill again quoted that the definition of success is to go from failure to failure but still retain enthusiasm. So, but I think in the reperfusion therapy has been a big win for the stroke field, and we shouldn't underplay the extent of that win. In fact, reperfusion therapy for stroke is a far more powerful paradigm than acute coronary artery stenting for myocardial infarction. The numbers needed to treat are an order of magnitude lower. I believe that the immediate future is likely to remain reperfusion therapy, using very different techniques perhaps to what we're using now, and I think this is part of the journey that we will all enjoy and appreciate. Thank you very much indeed, and thank you to the patients here today.
Thank you, Dr. Davis, for a riveting talk. I'm sure you all agree with me. It was fascinating to hear all these wonderful experts talk about these compelling topics. This session is now closed, and we'll be having the main event at 10:30 downstairs.